Having practiced dentistry or taught for nearly 55 years, I've heard all the reasons that patients can give for not flossing. And other than being just simply lazy and refusing to do it, here are the 4 things that seem consistent in talking with patients who don't floss. The excuses that they give are, my fingers are too big to get in my mouth, my teeth are too close together, it makes my gums bleed, and it hurts. Now let's talk about flossing an unhealthy mouth compared with flossing a healthy mouth. And quite frankly, these are entirely different. Common flossing mistakes. There are 4 of these. Using too short a piece of floss, the inability to properly place the floss, trying to floss using 2 fingers, and that really confuses the patient, and long-term consequences of improper flossing, which I will demonstrate what happened in my mouth. My fingers are too big to get in my mouth. Notice how the patient, in this case me, has not wrapped the floss around the index fingers, and therefore there is no way to get the floss in my mouth. Here is a solution. First, wrap the floss around the middle fingers. The distance between the fingers should be approximately 1 inch. And here we see wrapping it around the middle fingers, but we're not done wrapping, for you still have 3 or 4 inches there, and that's still too wide, and the patient cannot get it in his mouth. Now on the right slide here, we're almost through, and now that distance between the teeth should be about 1 inch or less, as we have indicated here. Using too short a piece of floss. Use a piece of floss that is at least 15 inches long. This gives you plenty of floss to wrap around the index fingers and get the fingers close together so that you can properly floss. And you notice I keep talking about floss. Personally, in my mouth, I prefer dental tape to dental floss. It's a little more difficult to get between the teeth, but the broad area of the tape, I find, is much more efficient. Popping the contact. Popping the contact. We've all been told, don't pop the contact, don't pop the contact. In an unhealthy mouth, this causes pain and bleeding, and obviously you don't want to pop the contact in an unhealthy mouth. However, in a healthy mouth, such as my mouth, I pop the contacts all the time because the tissue is healthy, it doesn't bleed, and it doesn't hurt, and it certainly takes less time. Now, in an unhealthy mouth, notice how I am angling the floss on the facial. It's more apical than it is on the occlusal surface, and what you want to do is to gently saw through the contact and slip the floss beyond the contact before you start flossing. So that's the difference in flossing a healthy mouth versus an unhealthy mouth. Now, wrapping the floss around the tooth. Here we're flossing the mesial surface of the tooth and the distal surface of the adjacent tooth. Notice that we have 2 fingers. The index finger on the facial is what I refer to as the action finger, and the one on the lingual is what I refer to as dead weight. In other words, you don't floss with 2 fingers, you only floss with 1. And I think this is very confusing to patients because they're trying to work 2 fingers, and certainly don't have them look in a mirror when they're doing it, for that's like backing a trailer. And this is one of the things in the clinic I saw all the time, is students holding up a mirror so the patient can see the floss. Flossing is not a visual thing. It's visualizing what you're doing, visualizing what surface you're on, and using the proper finger. But the finger on the lingual is always also the dead weight. Now as we're doing the distal of the canine, not the index, but the thumb is the action finger. And what I want you to notice is how we can slip the floss slightly beneath the crest of the gingiva into the sulcus and get any plaque that's off in the subgingival area. And this is where I got into trouble on my lower right molar number 19, because I kept sawing like this, and you're going to see the notch that I created on that tooth. So the thumb on the facial is the active finger, and the one on the lingual is or the palatal is the dead weight. All right, I mentioned what I did in my mouth. Here we see my number 19, and you can see where I have cut into the area just apical to the cemental enamel junction by sawing that floss and overdoing it there. Probably took 40 or 50 years maybe to get there, but I began to have some chipping on the occlusal surface and cracking, and elected to have an onlay or a 3/4 crown done on that. And here you see the 3/4 crown in place, and look at where the margin is, right where it's supposed to be. But this shows you how you can be fooled by x-rays, because it looks like I should have had crown lengthening done and before that onlay was done. However, I had that done about 5 or 6 years ago, and I'm 80 years old now, and there's no way that I'm ever going to get any caries there. I haven't had any active caries in probably 40 years. So this is the onlay that was done by my good friend, Dr. Bill McHarris. Now, let's look at the video. You've just seen the slideshow that I did on flossing, showing technique. Now let me briefly show you how that's done in the mouth. Now remember what I said. Don't get too short a piece of floss. This is about the right length, about 15 inches. And you want to wrap it around your middle fingers, just like I'm doing here. And wrapping it down, and see how close my fingers are. Remember I talk about if you've got it like this, you can't put it in your mouth. So therefore, if you have a healthy mouth, remember what I said, I don't hesitate to pop the contact. But if you've got a diseased mouth, what you want to do is, rather than put this in like this, you want to angle it, work it through the contact, and then we're going to be flossing the mesial of this tooth. And notice that this index finger is the active finger, whereas this is a static finger. Notice how rock around. Then when we do the mesial, the canine, remember, the thumb is a flossing finger. And we also talked about what I did to my lower right first molar. And I still have trouble flossing that tooth, because when I go there, I have no problem. I have no problem on the second molar, but I have the damnedest time trying to get on the distal of that first molar. And so this is what I did for years, and sawed into that. And I found it easier, as you probably do right there, when I floss, just pull the floss through. Now on the lower anterior, let's demonstrate the difference between popping the contact of a healthy mouth and an unhealthy mouth. Let's assume that I have significant periodontal disease, puffy gums, irritated gums, and I certainly don't want to do that. So what I do is angle it like I mentioned earlier, work it through, and in this case, in the lower anterior, we're going to just use the 2 index fingers. This one is going to be the flosser. Now we come over, and the thumb is the flosser. You can't do both teeth. It just doesn't work. So therefore, hopefully the things that I've shown you will make a difference. Maybe you can change your flossing technique, teach your patients how to do that, because interdental cleaning is so very, very important.